A very good evening to everybody. So I cordially invite all of you and all the consultants, both in radiology, pathology, radiation oncology, medical oncology, and surgeons and experts for our today's evening meeting on newer targets in ALK+ non-small cell lung cancer. This meeting is from Freedom from Cancer, and thanks to our Novartis partner who is helping us to do the meeting, and Kavina Creations for all the digital platform we are having today. So I hand over the mic to our chairperson and expert, Dr. Rajeshwar Singh, medical oncologist in Panchkula, and to invite the first speaker of today's session, Dr. Krishnamurthy.
Thank you, ma'am. It's a pleasure to be present in this conference. So, when I joined oncology, I could have never imagined that a pill a day or 2 pills in a day can, help any lung cancer patient to survive for 4 to 5 years. So we have progressed a lot in 1 decade. It was a nihilistic disease like pancreas before, but now we have so many options. In fact, standard chemotherapies in the Western countries nearly out. Whether it is immunotherapy, immunochemo, or if we have this driver mutation positive, then we have TKIs. And a lot of discussion has occurred as far as EGFR mutated lung cancer is concerned, and very few discussions on ALK+ like the one we are having today. When we asked for these tests, many of our oncologists are still, they simply write EGFR, ALK, or ROS. Now, what platform to be this test to be sent, whether to be sent by ISC, whether by NGS, or whether by FISH, people don't write because there are specific indications for approval for all these tests. So, moving this ball rolling, I now request Dr. Krishnamurthy, from surgical oncologist from Cancer Institute, Adyar. He'll be talking on molecular testing in lung cancer, recommendation to clinical practice. Dr. Krishnamurthy, please.
Yeah, good evening, everybody. At the outset, I would like to thank you, sir, and also thank Dr. Anita, Ramesh, and also the Kavina Creations team for the opportunity to speak. At the outset, I must say this is a very niche topic for me as a surgeon to speak, but I'll try to do my best to give some of the surgical perspectives along with the molecular perspectives. Traditionally, lung cancers was considered a lethal cancer. And prior reports said that lung cancer resulted in more deaths than breast, prostate, colorectal, and leukemias put together, especially in men more than 40 and women more than 60 years of age. However, with the introduction of screening guidelines, and I must confess that the screening uptake is pretty less, most possibly 3 to 5% of the world population. But more importantly, due to a decrease in tobacco use, we have seen a decrease in the mortality rate of lung cancers over the years, and this is a global phenomenon, about 48% in males and by around 23% odd in women as well. And this is because of molecular targeted therapies that we have seen over the past 2 or 3 decades. For the diagnosis of lung cancer, we know logically earlier stage is associated with better survival. So as primary care physicians, or every primary care physician should investigate high-risk symptoms, even though they are not specific. Just to put things in perspective, we need imaging tests, we need a tissue or pathological review to confirm the diagnosis of lung cancer. Tissue diagnosis till date is and continues to remain the gold standard, and tissue for molecular testing can be more commonly used from or obtained from formalin-fixed paraffin-embedded blocks. An important consideration is that the tissue can be procured either from the primary tumor or from the accessible metastasis. For example, if the patient has got a supraclavicular node and a lung cancer, and if the supraclavicular node is amenable for biopsy, then it could be one of the options to obtain a tissue diagnosis in that way. And doing that, you not only stage the disease, but you also sort of obtain tissue for molecular testings. How do you actually go about arriving or approaching the tissue of concern or of importance? For centrally located tumors, bronchoscopic yield is pretty good. Squamous cell carcinomas traditionally tend to have a central location. About 65 to 68% yield with bronchoscopy is there. Especially if there is adenopathy in either of the histologies, the use of EBUS now in the staging or the mediastinal staging for lung cancers, the yield would be around 75 to 78% with the use of EBUS TBNA. More recently, we have evidence to say that cytological specimens obtained from EBUS TBNA is suitable for certain molecular studies like the EGFR, KRAS, and ALK, but not FDA approved for other molecular testings. If the lesion is peripheral and more so in case of adenocarcinomas, image-guided transthoracic core needle biopsy with an yield of about 88 to 90%. But one of the issues of image-guided transthoracic core needle biopsies is the procedural risk of pneumothorax, which may occur in up to 70 to 50% of the times. But fortunately, major pneumothorax receiving any needing intervention will be very less, maybe around 5% or max around less than 10% of the cases. So you can sort of reach a tissue diagnosis by image-guided transthoracic route. What is the recommendation is to have a least invasive approach to have the highest diagnostic yield, and whichever is there as per the case, it mandates, as I said, peripheral, central, nodes, supraclavicular, pleural effusion, bone, or whatever it is, you'll have to make the distinction on a case-by-case basis. As I already said, if a supraclavicular node is palpable, present, you could use it as one of the modalities to achieve a tissue diagnosis. Any non-regional node also can be used. In case of bone biopsies, which are treated with non-acid decalcifying solutions, it can actually be used. If you have used an acid decalcifying solution, then it becomes very, very difficult for the bone to be used for molecular purposes. In pleural effusion, considering the fact that more than 50% of the lung cancers we see would be metastatic, a great majority of them would have a wet lung or a pleural effusion, you could do a thoracocentesis, have a cell block done and use it for molecular analysis if you wish to. It gives the added advantage of also being therapeutic in terms of a palliative treatment for pleurodesis. If the fluid cytology is negative, then you could consider an image-guided pleural biopsy or a surgical thoracoscopy. Any more invasive surgical steps like a mediastinoscopy, a mediastinotomy, or a thoracoscopy, or a VATS should only be considered when any of the above mentioned procedures, that is your bronchoscopy, EBUS, TBNA, image-guided, any other accessible nodes or effusion, if it is all negative, only then you should consider an invasive surgical approach for making a diagnosis. And this is especially true in cases of advanced or metastatic lung cancers, wherein you would require the tissue for diagnosis and molecular subtyping. Oh, I don't know why this thing is not. Can you see the cartoon, or it's possibly, I'm not sure why is it not there, but I would go on. The evolution of lung cancer diagnosis has moved from cytology to histology to currently molecular. In the years when I used to train, cytology of carcinoma would be adequate. Now we know it's more to do with the histology and molecular subtyping. Okay, yeah, here it goes. Okay. Histological classification is very crucial. We know that histological directed therapies have been there ever since 2007 or 2008. And to know whether it is adenocarcinoma or a squamous cell carcinoma is very, very important, because it has a great therapeutic implication, at least in your choice of chemotherapies, apart from many other things. We now know that non-small cell lung cancer is not just one disease, but a constellation of many other diseases as well. In 1990s, as I said, the understanding was either small cell or non-small cell. Non-small cell constituted around 80 to 90%, and it was enough if you could get the diagnosis as non-small cell at that particular point of time. Whereas in the early 2000s, we needed to know whether it's squamous, adenos, or any other histologies. But now, in the adenocarcinomas, there is a molecular subtyping. And close to 60 to 70%, in fact, the numbers vary. In the French study, to 50% of the adenocarcinomas could be molecular subtype. In the US study of the lung cancer consortium, mutational consortium, of 60 odd %. And with every increasing time, we find more and more amount of adenocarcinomas are able to be subtyped, close to 70% now. So only about 30% of the adenocarcinomas would now have no known oncogenic driver mutations. Majority of the mutations would be KRAS, and the numbers are variable. For example, EGFR sensitizing mutations could be around 10 to 15% in the Caucasian population. In India, it could be around 25 to 30%. And there are a lot of studies to say that in Asian countries like the Japanese, the numbers could go much higher to about 50 to 60%. ALK again, anywhere between 2 to 7%, and all the other remaining mutations in the area of about 1 to 3%. So it's very important that we have a metastatic adenocarcinoma in today's age. We must subtype this and know what is the targetable mutation. So it's very important to understand that these tumors are driven by driver mutations. And there is a phenomenon called as oncogene addiction, which is very important. And what is more important is our ability to target the mutations. It's not just important that you have a driver mutation, but if you have a targetable driver mutation, this was some review that I had written about 9 years prior, relevant even today. So that gives the added advantage of treating these patients. The importance of driver mutations is the fact that they represent very strong biomarkers with a very excellent therapeutic potential. The other thing is that they tend to be mutually exclusive to each other in the majority of the time. So although in 1 to 3%, you may have some 2 or 3 driver mutations, but it's pretty rare. And this is the reason why you could possibly, in some cases, do a single plexed assay versus a multiplex assay, considering the fact that they tend to be mutually exclusive. For example, if you have an EGFR mutation, very, very unlikely that you tend to have a KRAS mutation. But of course, as I said, that in about 1 to 2%, it could be positive. And again, there are certain clinical characteristics. These driver mutations tend to be present in never smokers. There are some mutations like KRAS and BRAF mutations which tend to occur more common in smokers as well. And a lot of them tend to occur in adenocarcinomas. So the guidelines suggest that all patients with advanced or probable or definite adenocarcinoma should be tested with the oncological driver mutations. Molecular testing not recommended in squamous cell carcinomas, but in certain rare situations in which the tissues are small, it's a poorly differentiated tumor, it's an adenosquamous histology, or it's a young patient who is a never smoker. So these are certain circumstances in which, even if there is a squamous cell carcinoma, you could consider a testing for a driver mutation. I alluded to this study, the French study, about 50% of the times they could achieve a driver mutation. As I said, lung cancer consortium, it was around 60%, and now with around 70% of the adenocarcinomas are able to have a targetable or are able to identify a mutation, and majority of them could be targetable. Now, what mutation to be tested? And that's the really next question. Testing for EGFR and rearrangements for ALK and ROS now considered mandatory, and this is a part of the ESMO guidelines. BRAF mutations and also BRAF and MEK with inhibitors is something which is coming up. HER2 and MET exon mutations and fusion genes of RET and NTRK are now evolving, and we now have targeted therapies for this. PD-L1 testing by immunohistochemistry, again, this has become mandatory. And what method to use? I think it's a very sort of a big topic, whether in cases of EGFR, whether you do it by a PCR or a next-gen sequencing. And almost all of these mutations could be sort of studied by means of a next-gen sequencing. In case of, in certain other mutations like the ALK, the ROS, and the MET, you could use a FISH, but in more and more cases in ALK rearrangements, there is more evidence to say that immunohistochemistry is also almost equivalent, and you could sort of, it could be a surrogate marker for ALK positivity. And we are also doing some study to validate this finding by itself. PD-L1 is something that you cannot do by NGS. You will have to have an immunohistochemistry done for PD-L1, and of course, what immunohistochemistry, what cutoffs of PD-L1, what tests, and so there are a lot of controversies, and I don't really want to dwell into that in the interest of time. The other question is whether you do a standalone testing or a multiplex testing. Majority of the laboratories, and this is in real world data, they tend to go for, at least for EGFR and ROS, they tend to go for standalone tests. But again, more and more recommendations and NCCN recommendations says that you should try to go for the multiplex testing or the next gen sequencing, which is slowly becoming a gold standard. And as I mentioned about the PDL1 testing as well. Again, the importance of comparison of single gene testing versus multi-gene testing is essentially because of the tissue. Lung tissues in a biopsy is very scarce, and especially so in a metastatic setting wherein you tend to get very, very small bits of tissues. Unlike in an early stage setting, in a surgically operated patient, you would get a lot of tissue, but that is not the case in a metastatic tissue, in which you will have to get either a bronchoscopic tDNA or image guided, where the tissue is going to be very small. You do a single gene testing, you start testing one after the other, then your tissue tends to get exhausted, and you may have to do a repeat testing, or you may have to go for other sort of tests of cytology or blood-based markers. The main advantage of a multi-gene testing is that it minimizes the use of the tumor tissue and facilitates multiple biomarkers. Now, also we would get to know much more additional information. Of course, there are costs are an issue, and the way you interpret the data are also other issues. But of course, there are limitations being there are multiple platforms are available. There is complex biomarker response. There needs to be a quality check. Pre-auth requirements are there. And in real world, it may not be possible for every patient to have a multi-gene testing by the NGS platform. As on March 2020, we had these set of mutations that could be targetable: EGFR, ALK, ROS, BRAF, and NTRK. But subsequently, that is in June, and this year has been very good for the biomarkers in non-small cell. Almost about 7 new approvals have been come. A lot of the publications have come in the NEGM itself. And apart from the EGFR, ALK, ROS, BRAF, and NTRK, you have the RET and the MET testing, which is there. You have targetable drugs which are available, which can have an impact on the progression-free survival for these patients. Again, as I said, that when you see the broader perspective, right from 1780s to where we are right now, over the years, with the use of combination chemotherapies, the survivals was about barely around 6 to 7 months. And now with certain mutations, almost we have reached almost a survival of close to more than 45 months with the advent of newer targeted therapies. And finally, I would want to cover this point, that is, a tissue is an issue which I have said. So there's a lot of learnings for the molecular pathologists as well. How to handle small tissue biopsies is something that they'll have to really sort of be very good and adapt at. In real time, you don't really get a lot of tissue. 40% of the diagnosis still by cytology, and that's going to be a major challenge. So the use of immunohistochemistry should be very limited, only in cases in which the NSCLC is not able to be subtyped properly. Any one of the marker, TTF1 or napsin in case there's an adenocarcinoma, or P40 or P63 for squamous. In fact, they say that if you are doing a immunohistochemistry with TTF1 and P40, you should be able to sort of, in majority of the cases, you should be able to get or subtype the non-small cell lung cancer. And non-small cell lung cancer NOS rates should be less than 10% in the modern day and age. So the new journey for testing right now is to first establish the malignancy, second, subtype the malignancy, and if it's an adenocarcinomas, in majority of the time, perform a testing for them. Finally, a word about liquid biopsies, especially in cases in which the tissue is very less, tissue is unable to be procured, or in medically unfit patients. This is something that you could do. The advantages being it's minimally invasive, can overcome tissue heterogeneity, but the issues are that the sensitivity would be around 70 to 80%, and a negative result is not always conclusive. Of course, you have a lot of provocative data by the Nile study saying that you could have up to a 48% increase in the rate of biomarker detection with the use of ctDNAs as compared to tissue diagnosis alone. But as I said, a negative tissue a liquid biopsy does not rule out the presence of an oncogenic driver mutation. And still in the current clinical age, tissue is still considered the gold standard for management. You have two FDA-approved tests, the Guardant360 and the Foundation One testing. I'm not going to the details in the interest of time. And very sort of encouraging data also coming up with regards to tumor mutational burden based on the subset analysis of the popular Newar studies. Tumor mutational burden has been found to also have a predictive biomarker for PFS in patients who have receiving atezolizumab in non-small cell lung cancers. And even liquid biopsies also can not just be used from the therapeutic perspective, and it could also be used to detect not just the CTCs or ctDNA, but even the miRNAs. And these are some markers that we sort of envisage that it could be useful in lung cancer detection or lung cancer screening itself. So the potential for liquid biopsies is sort of increasing with the current time and age. So I would conclude by saying that in lung cancer, the optimal management of biopsy specimens is very, very important. You must sort of, because tissue is the issue, the tissue is small, we need to use it very meticulously and judiciously. Primary tumors or metastatic lesions, both are suitable for molecular testing. I think bone biopsies is suboptimal generally because of acid decalcification, but with non-acid decalcification methods, I think they're trying to sort of see whether we could get some sort of tissue from the bone as such itself. A lot of data on liquid biopsies and cell-free DNA. Testing for PD-L1 expression now is mandatory for all non-small cell lung cancers. And again, as such, as I said, reiterated, testing for EGFR, ALK, ROS, BRAF, NTRK, RET, and MEK, and you all have targetable drugs for these. And it's preferable that we tend to do a broad NGS testing is encouraged for all these patients. And the criteria for small cell and non-small for squamous and adenos I mentioned as well. And as I said, these are very interesting times for liquid biopsies, and this is something that I'm sure that in the coming days we would see more and more of liquid biopsies, especially in the retreatment or in the phase in which you are treating a patient in a relapsed setting, especially in advanced or metastatic non-small cell lung cancers. And with these, I say I would conclude my talk, and thank you, Dr. Anita, for the opportunity. I was very brief, and because it was a lot of ground to cover, I'm sure in case there are any questions, I think they would address it in the panel or in subsequent talks. Thank you.
Yes, Dr. Krishnamurthy, thank you so much. Is Dr. Manikandan around to give us the expert
Hi, yes, ma'am. Yeah, good evening, ma'am.
Nice to see you. Yes.
Nice to see you, ma'am.
Yes, please carry on.
Good evening, everybody. Thank you, sir, Arvind sir, and thank you, Anita, madam, for having me here. Sir has spoken extensively about the topic. I think there's very little to talk more on that. But as sir said, I think the problem that we are facing in the ground reality is that most of the time we don't have adequate tissue for biopsy. And usually the diagnosis happens elsewhere. Then the patient moves around to, bounces around in multiple places. And then when they come with inadequate tissue, and sometimes IHC is done. You have to take repeat biopsies. All this prolongs the time to initiate treatment. Moreover, I think the turnaround time for tests is also high. Although we say it should be within 10 to 14 days, most of the time, I find that, when the companies ship the samples to out of station, sometimes even abroad, the turnaround time can run into, 3 weeks to 4 weeks also in some cases. So I think these are things which we have to still work on and to cut down, to improve our efficiencies, so to speak, and hopefully that will be the future. And a promising alternative is liquid biopsies, as sir mentioned repeatedly. Liquid biopsies can offer a lot of advantages, especially in our system. And as the treatment in non-small cell lung carcinoma, especially adenocarcinoma, is drastically moved towards targeted therapy compared to conventional therapy. Just one question I would like to ask my medical oncology colleagues, that is, Suppose in this case, as there is a lot of delay, sometimes patient general condition is progressively worsening, and when they come to us with probably an ECOG2 moving towards 3, can we wait for a longer time to get these targeted therapy results before starting treatment, or can we start conventional chemo and then when the results come, can we put them on targeted therapy if affordable?
Yes, Dr. Manikandan, answer to your question is that we need to differentiate the patient whether they are in visceral crisis or not. But then
Yes,
somebody who is in visceral crisis like breathing difficulty, massive pulmonary effusion, okay, say cerebral mets, deeply jaundiced with liver metastasis, those are the cases where we need to start with the supportive care. In some cases, we may not be able to wait for the reports to come, the ALK report to come in. But definitely, one thing is with these inhibitors of the ALK inhibitors, even in a emergency condition, also patients have done well. So there you have to use your clinical decision and see what can be done. Patient very sick, poor performance status, yes, you can decide we can start these ALK inhibitors, they do well. But again, patient has multiple organ failure, yes, there we may not be having that much time to wait to get the results and start these inhibitors.
Thank you, ma'am. Thank you.
Just a comment, madam. We guidelines are there. Once you send for biopsy, you need not wait all the time. If patient condition is such, you start the chemotherapy, and even if the result of the driver mutation come, you can, if the patient is responding to your treatment, you can continue treatment, and thereafter you can change over to TKI. So these are the guidelines for even for driver mutation also.
Okay, thank you, Dr. Rajeshwar. Let's move on to the next topic, the recent updates in therapeutic landscape for ALK-driven metastatic non-small cell lung cancer. I invite Dr. Ashish Singh from CMC Vellore to take us through the talk. Dr. Ashish, please. Dr. Ashish.
Ashish sir, are you able to hear us? Hello, sir. Can you hear us? Ma'am, we'll just wait for a minute. I think he's just logged out. Yeah, I think so as you. Ashish sir, can you hear me?
Hi.
Yeah.
Yes, I can. Can you?
Yes, sir. We can hear you now, sir.
Okay. Sorry. I'm just sharing my screen.
Sure, sir.
Kashish visible?
Yes, sir. Your screen is visible, sir.
Yeah. Hi. So good evening, friends and colleagues. Once again, very welcome for this Novartis sponsored meeting, and thank you, Dr. Anita and Dr. Kavish sir, for the invitation. So as we all know, the theme for today's meeting is ALK positive advanced lung cancer. And we just had a fantastic overview of different kinds of mutations we see in different cancer and in lung cancer. And also, especially in the last 3 years, we have been seeing almost every mutations listed here has been targeted. Even the mighty KRAS, now we've got an inhibitor. But if you actually look at what progress you have made with all these in oral tyrosine kinase inhibitor, ALK remains one of the I would say the poster boy of all these mutations, because the kind of responses and the kind of survival advantage and the number of years these patients live is actually, I think, is unbeatable, even better than the EGFR story what we started with. Now ALK mutations, again, there is some geographic variations. There are series where they report mutations anywhere from 2% to all the way up to 8 to 10%. Now, just to, I will not go into testing, but just to tell you that ALK rearrangements or ALK mutations or ALK aberrations, you may call, can be tested through any of these 4 listed gold standard methods. Now, each one of these they have their own pros and cons. IHC is the most rapid one. You can do the staining today and you have the report tomorrow. However, in many times where when you do IHC, you use up a lot of tissue, and therefore it's possibly not the preferred one. Now, everyone talked about so many targets, so many testings to be done. Now, again, you also have to realize that when you do multiple tests, you do use a lot of tissue, and therefore it's actually a challenge on how to test and what do we test. So if you look at the recommendations, most of the recommendations would say they strongly endorse broader molecular profiling. However, in our setting, it becomes a challenge now, because one thing is the cost. Second thing is somebody said turnaround time. Third thing is our patients do not have access at the moment. So even though the future is multi-gene panel testing, however, current and we all should strive to have that in our centers in the next few years. But currently, even at our center, we would with the initial panel of IC, we would ask the pathologist to do the PDL1 and ALK, and then the block goes for the RT-PCR, through which we get EGFR. We do the ddPCR, so we get it in about 3 to 4 days. And it's only after we have looked at the ALK EGFR, that's when remaining some these newer drugs, say matinib, selpercatinib, entrectinib, all still to come in. Now, I just want to it is also a NGS, which this test is available. We're using it a lot, and a turnaround time of about 1,000. This is something which has been very useful. Now, once you have an ALK aberration picked up, what are the options we have? So historically, if you see, one of the first drugs which came in this space was crizotinib by Pfizer. Interestingly, crizotinib was not developed to be an ALK inhibitor, to be a ROS inhibitor. And they discovered that it also has ALK effect, and they were actually quite good and quite rapidly. They did their trials and it got approved. Now, if you look at the next set of drugs, the second generation, was one of the earliest, which was designed. Subsequently, the lot of trials, global trials, group stasis station. So we have a wealth of data with this drug serotaxib, which we'll discuss in today's meeting. Parallelly, there have been other players, like which was predominantly
Ashish sir, can you hear me? Are you able to hear me? Ma'am, should we wait for a minute?
Yes, I think he is having a little bit of thing. Dr. Rajesh was saying, in the meantime, you can continue with your expert comments till he joins. Yeah, Dr. Rajesh was saying.
Raj,
Okay,
sir.
okay, I'll do that.
You give your comments. We wait for him. You continue with your comments, please.
You see, we all know that ALK mutation, it occurs in roughly about 5 to 7% of non-small cell lung cancer patients. And these patients are younger, generally non-smoker or light smoker. Signet cell or acinar histology is commoner in this. And for testing, basically, it is like already told by Dr. Ashish, is that ISC, NGS, and FISH which are done for testing. And the best is FISH and NGS, of course. ISC is a special Ventana platform, it is done. Now, first trial was of crizotinib, which came in 2014. And in that trial, many of our patients are surviving till 4 years also. Subsequently, ceritinib came and ASCENT trials were there, and it shows the hazard ratio of 0.55, and even in brain, a hazard ratio of 0.7. Uh, Dr. Ashish,
Um,
you're there?
yes, I'm there. I
Yeah,
don't
yeah,
know on which slide you lost me. So I just finished. I hope I'm audible.
yeah, you're audible.
Okay, so I just finished just comparing the first line trials. And now, as you see here, there's a clear doubling of progression-free survival from 8 to 16 months and an impressive response rate of 72.5%. Now, we have a long-term overall survival data of the first trial, the Profile 1014 trial. There, in spite of a very impressive overall survival of almost 4 years by crizotinib, there still was no difference between overall survival when you started with chemotherapy versus crizotinib. So that just tells you the importance of subsequent lines of therapy in all of these trials, which are extremely important. But one place where most of our patients failed, especially on crizotinib trial, is in the brain. And one of the reasons here is possibly that crizotinib has poorer brain penetration, and therefore, in spite of the disease being well controlled elsewhere, these patients fail in the sanctuary site of brain. Uh, to begin with, if you see about 30% of your patients, if you screen actually meticulously using MRIs, may have tumors in the brain. But however, majority of your patients would still be at presentation, they will not have brain metastasis. Now, when this trial was diagnosed, was conceived, that was ceritinib dose was 750 milligram per day, and it was compared to standard of care chemotherapy. Now, in the ASCENT-4 trial, brain metastasis was allowed. It was, irrespective of they were symptomatic or not, they all had treated brain metastasis with radiotherapy, and they were randomized. And crossover was allowed. So that is an important thing here to note, because I've seen recently a trial of lorlatinib versus crizotinib where no crossover is allowed. Sometimes drug companies do that to show an overall survival benefit. However, that doesn't give you a true picture when the drug gets approved. Then whether it's really important, depending on what drug you choose upfront. Now, this again, I just mentioned there was almost a doubling. If you look at these curves, they separate quite early. This is something which is different from the crizotinib versus chemotherapy, where the curves go together and then the benefit is actually seen only after 6 months. But here the curves separate quite early, right from the first scan, that is at 2 months. Now, you all will have this question in mind. We know that crizotinib does not work in the brain. What about ceritinib? Now, if you see in the ASCENT-4 trial, if you predominantly look only at the 30% of patients who had brain metastasis, there, if you were on chemotherapy, you progressed within 6 months. But if you were on ceritinib, so you went on till 10.7 months. So this is a clear sign that ceritinib does work in the brain. Agree, it may not work as good as the third generation drugs. However, it has a but more importantly, if you see in patients who do not have brain metastasis in the beginning, where there you see the PFS is almost 3 times, 8.3 versus 26.3 months with ceritinib in ALK+ advanced lung cancer. Now, let's try to look at, does ceritinib produces responses in the brain? This is what analysis presented here. This is overall intracranial response rate. And even in the brain lesions, small number of patients, 22 only. However, you see that responses occur in almost 72% of them, clearly showing that this drug has some intracranial activity and efficacy. And it's just the mere presence of brain metastasis does not mean that you have to resort to any of the third or fourth generation drugs. Now, if you look at the overall survival data here again, there is a trend towards positive. I mean, this is in spite of crossover. However, this analysis is only interim analysis, and only 42% of events have occurred so far. Now, we have data of hazard ratio of 0.66 when compared to chemotherapy, and then you see that the difference is almost similar to what we have seen in the other trials. How does we all know alectinib, the landmark ALEX and the JALEX trials? If you see there, even alectinib versus crizotinib, the curves, the progression-free survival curves goes neck to neck by for about 6 to 7 months, and subsequently they converge. They diverge. And if you see predominantly where do these patients progress? They progress in the brain, and alectinib is able to suppress that. So a lot of the benefit of alectinib is actually due to extremely good intracranial control and prevention of CNS metastasis. That's something which we all need to remember. Now, what about quality of life? Now, we all know in lung cancer, if you control the disease, your quality of life immediately is better. However, with chemotherapy, you do get some, for the first 6 months when you're on the treatment, you do have some worsening. Here, when you compare ceritinib versus chemotherapy, those patients do well on all aspects, including disease-related symptoms and also treatment-related adverse events, and much lesser. Now, another interesting thing, what has happened after actually the approval of ceritinib was this discovery that if you take ceritinib with food, absorption is much better, and therefore you may be able to reduce the dose without compromising on efficacy, and while doing it, you may be able to reduce the side effects. And this is a proof this is a randomized trial, open label, which shows that if you take 450 milligram with food, it's equal to taking 750 milligram in fasting state. And there was a third arm with 600 milligram, which led to higher doses. And it clearly shows here that by taking 450 milligram, your responses are not compromised at all. Your disease control rate is almost 90%. So your duration of response was actually it was best in the 450 group which was taken with food, including the progression-free survival. So after this trial, actually 450 milligram with food has become the standard of care and also the approved dosage even in the West. Now, by reducing the dose to 450, we did manage to bring down grade 3, 4 diarrhea, vomiting, nausea, predominantly the GI adverse effects, so much so that this drug has become much more tolerable as compared to what it was at 750, and also if you compare it with other drugs. Now, this cross-trial comparison we actually do not do, but however, there are people who, when they have looked at doing a matched indirect comparison, they found that ceritinib is, especially if your patients do not have a brain metastasis, does produce almost an equivalent kind of PFS, the hazard ratios in the beginning. So now with all these options available, you all must be wondering, is it actually important which drug to start? Is there a perfect way of sequencing these drugs? Now, one of the most important thing, I think, when you choose a drug where patient is going to be on treatment for a very long time is actually tolerance and side effects. If your drug is not going to be tolerated well, nobody's going to take it for 2 or 3 years. So therefore, when you compare side effects profile, ceritinib 450 milligram, actually, the main thing you have to watch out for is nausea, diarrhea, and change in liver functions, which again in terms of grade 3, 4, if you see, is pretty low, which may not be the case with your other next generation drugs. Now, these patients, when they progress, they usually progress because they develop mutations in different regions. And these mutations are different depending on what drug the patient is on. And one of the mutations which is extremely resistant to most of the other available drug is this G1202 mutations. And therefore, there is a need to develop better drugs. And there has been an interest and research predominantly lorlatinib seems to be one direction. You have alectinib, which is approved even after progression on first line TKI, actually does not work against G1202R. Now, even though this table looks good and all of us would want to have this information, you must remember that this data is actually from cell lines. Whether this holds true in the real patient, we do not know. Also, we need to do liquid biopsies to pick this information up. And as of now, there is no standard test which can actually give you, or a standard lab, validated lab, which can actually give you all this information reliably. So even if you look at the drug approval by the regulatory authorities, if you look at lorlatinib, it is not based on any mutation testing. So So in clinic, we just simply look at what drug have you chosen before, and then what you've not taken, and then do we have any data to show that a drug B would work after drug A. For example, if you have started on serotinib and subsequently you can choose any of the other drug. However, we know that if you progress on alectinib, lorlatinib may still be still work. However, the reverse we do not know. So a lot. This is still an evolving field, and I'm sure drug companies will try to position their drug in a way that it moves forward. However, we have to remember that for our patients, it is going to be a long journey, and it's extremely important that we keep good drugs to be used later and not use all our options upfront. One thing to note here is that crizotinib is currently not the preferred first-line drug, even according to the guidelines. So they say that you should resort to crizotinib only if you do not have access to any other ALK inhibitor. Mainly because we know that's in terms of the first-line PFS, it is actually the most inferior. So with this different sequencing strategies we have, now what we need to do is our goal should be that our patient should do extremely well for at least for about 3 to 4 years. And it's not that we have to use all the alectinib or lorlatinib up front. If you sequence just serotinib or crizotinib followed by serotinib, you do reach there. And as an important thing that we try to read together particular trial and make decision. Even this drug called brigatinib is not available, but if it becomes available in future, it's a pretty effective drug. Now, just last ESMO, we saw the CROWN data where lorlatinib had better PFS than crizotinib, but that's kind of not relevant now as we know that crizotinib is no longer the standard of care. And then the lorlatinib not allow the crossover. So we at least let's see how the OS data pans out with that. So now with that, I'd like to conclude saying it is a very satisfying disease to treat, and it's no longer just a decision you have to make regarding first-line therapy, but you must sequence in your mind, discuss with your patients, and use all options so that our patients can still survive and this becomes a chronic disease at least. Thank you for your attention.
Yes, thank you, Dr. Ashish. Okay, I think Dr. Rajesh has already given the expert comment, and I think we are on time. Okay, thank you, Dr. Ashish. It was a good talk. Let's move on to the case-based discussion, and I invite Dr. Prem Kumar Devadas to take us through the panel discussion, case-based discussion on ALK-positive metastatic non-small cell lung cancer. Even I invite Dr. Nafis Ahmed Siddiqui to invite the panelists and give his expert comment. Dr. Siddiqui.
Hello, ma'am. Good evening.
Yes, good evening. You can introduce the panelists.
Hello. Hello.
Yes, please.
Yes.
Oh, yes. I'm sorry about that. Yes.
Yes, Dr. Prem Kumar, you're ready?
Yeah, I'm ready. I'm ready. I'm
Okay,
fine.
so
I'm
I
fine.
invite Dr. Rajkumar Ramaswamy, Dr. Manikandan L, Dr. R. Deepak, Dr. Bhavesh Koladia, Dr. Kripa Shankar, Dr. Jovika Martin, our pathologist, Dr. Chandra Mauleshwari, and Dr. Vandana Mahajan, our radiologist, as well as Dr. Vikas Talreja. Okay, you can start with the discussion. Dr. Prem Kumar, please.
Oh, yes. Thank you. Thank you. So good evening, everyone. And thanks, Dr. Anita and Novartis for giving me this opportunity. And can I have someone, operating my slides for me?
Yes, so
Kavina?
we
Yeah,
have the
good.
slides on the screen, sir.
Okay, so I should actually thank Dr. Arvind and Dr. Ashish for their very elaborate, elaborations on these. They were very specific and, they were actually terrific. So with this, we'll just move on to this case study. So here we are going to discuss an ALK positive NSCLC case presentation. Can I have the next slide, please? Yeah, this is a 54-year-old male person, a non-smoker. This is actually November 2014 for some interesting reason, you'll know, right? So this person presented with dyspnea, grade 2 dyspnea. The CT scan picked up an upper left-sided upper lobe lesion. Next slide. And as you can see here, he had symptoms of brain metastasis. So CT scan was performed, which picked up multiple brain metastasis at presentation as well. Can I have the next slide, please? Yes, so December 2014, bronchoscopy was done, DBUS performed, and came out to be lung adenocarcinoma with ALK rearrangement at ILC and FISH. And of course, we all know it's multiple brain metastasis at presentation. Next slide, please. So yes, let's just discuss the preferred treatment option. So if I can go to Krupa first. Hi Krupa, so what would be your choice? Would you go for chemotherapy with RT, brain RT, or would you, we're talking about December 2014.
Hi, sir. So
Hi,
good to
hi.
know that. Hi,
Yeah.
sir. So I think probably in 2014, we would not have had alectinib available to us. So I mean,
Exactly.
like in the present day scenario, I think that would be an easy choice. I would have gone in with alectinib. But probably I would have gone in with only ceritinib. I would not have gone in with radiotherapy because we all know that ceritinib has better blood-brain barrier penetration, and the intracranial response rates with ceritinib are actually much better than crizotinib. And ceritinib is a second-generation ALK inhibitor as well. So I would have in 2014, I would have preferred ceritinib. Given that that's the I'm out of all the options here, I would have preferred ceritinib. Given that the patient has brain metastasis, is asymptomatic for the brain metastasis, and ceritinib has good intracranial response rates because it can cross the blood-brain barrier, and it's a second-generation ALK inhibitor. So I would have gone in with ceritinib, sir.
Ceritinib. Okay, Dr. Bhavesh, any your thoughts on that? Would you differ or would you agree with Krupa?
I think if ceritinib was possible, definitely yes. If not, then probably WBRT followed by crizotinib would also be a good option, because post radiation, I expect that it will cross the blood-brain barrier and probably give a better effect in the CNS also.
Okay. Yeah, that's good. That's good. Now, I'd just like to ask Dr. Deepak. Dr. Deepak is here, right? Radiation oncologist.
Yes, sir. Yes, sir. Good evening.
Yes. Yeah, good evening. Good evening. Dr. Deepak, so this patient has symptomatic brain metastasis. So would you not give brain RT, whole brain RT?
Absolutely, sir.
Case?
Symptomatic brain metastasis.
Symptomatic
brain metastasis, I would definitely go with RT. Choice of chemotherapy rests with the medical oncologist. And as Dr. Bhavesh said very rightly, if after radiation, the blood-brain barrier is going to be a little more penetrable, it only helps with the chemotherapy drugs that we're going to use.
No, we all agree that we are going to give ceritinib. We are talking about December 2014 where we don't have a pattern. So ceritinib it's going to be. So do we still give whole brain RT? Yes, possibly because it's symptomatic brain mets. So anybody would like to differ on this? Jovita, Rajkumar, Manikandan? No RT at all and only ceritinib. Raj, yes, please. Yeah, sure, please.
So definitely one thing I have to keep in mind is we know that the most of the times the failures are in the intracranial whatever therapy we give, except for the alectinib, it's the intracranial failure that occurs during the therapy. So if patient is asymptomatic for the brain mets, I would give and preserve my RT at progression and tend to prolong, continue the TKI if it's only an intracranial failure to reserve the TKI at that time. But if the brain mets are symptomatic, I think a local treatment is definitely warranted.
Is essential,
be it ceritinib, be it alectinib, or be it crizotinib.
Correct. So I think we all agree with this. We've probably gone with the TKIs, ceritinib in this case. And if the patient is symptomatic, at that point we intervene and we do give, there is a role for whole brain RT, as well as we all know that stereotactic radiotherapy is also an option, something like gamma knife. So can I have the next slide? Yes, this is just to summarize the approach to brain mets. We all know symptomatic brain mets. Yes, as we all said, steroids and local therapy is indicated. Whereas asymptomatic, then we have all these choices, of probably ceritinib would be the best choice. And maybe later on, alectinib would have been a choice. Next slide. Yes, so this is just the evolution. So how it all evolved over a period of time. Like it all started with crizotinib. It was the first ALK inhibitor approved for NSCLC as early as 2011, and then came ceritinib. It was in 2015 we got the real approval for ceritinib. 2014 and then 15. Recently approved by FDA for previously untreated ALK positive NSCLC as well. And alectinib was only in 2017. It was approved for treatment in these patients who have progressed on or are intolerant to crizotinib in 2015 and the EMA in 2017. So we can take that as 2017. And recently recommended for approval for previously untreated ALK positive NSCLCs. Of course, brigatinib, as Ashish was rightly saying, is currently not available in India. It was approved in 2017 for patients with these same patients who are resistant to prior crizotinib. And lorlatinib, which is the recent generation, recently granted FDA breakthrough designation with for these same patients who have previously received at least one ALK inhibitor and progressed. Next slide, please. Yeah, once again, these are the NCCN guidelines for to approach the ALK positive NSCLCs. First line, as we all know, ALK positive, ALK rearrangement discovered prior to first line chemotherapy, then we always would have chosen alectinib, the present day scenario. Or if the ALK rearrangement has been discovered during first line chemotherapy has already been started, then you complete the planned chemotherapy, including the maintenance chemotherapy, pemetrexed, or interrupt, followed by alectinib or crizotinib or ceritinib. I would say probably alectinib or ceritinib until progression. And of course, subsequent therapies, we should all know that, as Ashish said, we have all these lines of therapy. So one progression after the other. If we had given ceritinib, we can go for alectinib and vice versa. And lorlatinib is also available nowadays. You should remember that. Next slide, please. Yeah, this is just to show the PFS of crizotinib versus chemotherapy, which was all extensively discussed by Ashish. So I really wouldn't go into the details. We all know that profile 1014 showed that crizotinib really had an edge over chemotherapy with a wide separation here in terms of PFS. Next slide. And as you can see here, this is the safety profile of crizotinib, and the side effects when compared to chemotherapy are very manageable. And if you notice grade 3 and 4, possibly it is the liver enzymes which we need to keep in mind when we give crizotinib. Next slide. Yeah, the crizotinib experience. Most patients, as we all know, develop resistance over a period of time, which is usually within a year or two. And we all know the mechanisms of resistance are pretty diverse. Usually it's the ALK resistance mutations and alternative signaling pathways like all these also come into play. So for this reason, we need other drugs that are more potent and more brain penetrable than crizotinib and have activity against crizotinib resistance as well. Next slide. Yes, so that's how the ASCEND-4 trial went out, where ceritinib was compared with chemotherapy, and it clearly proved that ceritinib achieved better progression-free survival versus chemotherapy, both with brain mets as well as without brain mets. In brain mets, as you can see here, the hazard ratio is like 0.48, a very healthy hazard ratio, and this is without brain mets. And even with brain mets, a hazard ratio of 70, which means a 30% edge over chemotherapy. Next slide. Yes, once again, coming to the safety profile of first-line ceritinib when compared to chemotherapy. As you would note, it's only usually the higher grade 3 or 4 would be the liver toxicities that you'll be concerned about, and also diarrhea. The incidence of diarrhea is pretty much higher. And as Ashish rightly pointed out, initially this trial went on with 750 dose mg per day. But when subsequently, I think we all know that the 450 dose is standard of care as of now, which actually decreases the rate of diarrhea and all that, the GI toxicity. Next slide. Yes, this is just a run through the ALEX trial where alectinib was used in the first line setting. So once again, this also has been touched by Dr. Ashish. So just to brief you, alectinib 600 mg twice a day versus crizotinib was compared. Next slide. And PFS was assessed. So the PFS of alectinib clearly shows, even right from the 6th month onwards, alectinib, the separation is pretty wide and the hazard ratio is 0.47, indicating a clear 53% edge of alectinib over crizotinib. Next slide. Once again, the key secondary endpoints of alectinib versus crizotinib in the ALEX trial, like assess PFS and yes, one important thing to note is the alectinib actually decreased the incidence, cumulative incidence of CNS progression. That's because the penetration is much better with alectinib than crizotinib. So for this reason, it really keeps the CNS progression at bay. Next slide. Safety profile of alectinib. Once again, if you look at higher grade toxicities, predominantly it's the liver toxicities that we need to keep in mind, and not much of GI toxicity, whereas the ceritinib has more GI toxicity than this. So it is pretty much manageable with alectinib. Next slide, please. So efficacy all in one, yes, we all know that the ALEX trial compared crizotinib versus alectinib clearly proved to be the winner, and ASCENT-4 trial told us that ceritinib is very useful, and brigatinib, we all know it's pretty much not available right now in India, but alectinib and ceritinib is really what we need to keep in mind in terms of progression-free survival and overall response rate and manageable toxicities as well. Next slide. Yes, so going back to the case, so this person, December 2014, ALK positive, lung adenocarcinoma. So January 2015 is when we start the treatment. So at that point of time, that was when the ASCENT-4 was going on. So the patient was enrolled on ASCENT-4 study, and the dose of 750 was started, but dose reduction from 750 to 600 was initiated because of intolerable nausea and diarrhea. Next slide. Once again, the primary efficacy and updated safety of ceritinib. So this is how we all know that 450 mg is now the standard of care. The dose of 450 mg ceritinib along with food is standard of care rather than 750 or even 600. We know 450 does not compromise on treatment outcome. At the same time, it's very manageable side effects. So we all know 450 mg is the standard of care. Next slide. Yes, ASCENT-8, where once again, this is how these trials proved that 450 mg of ceritinib is still good enough and without any compromise of treatment efficacy. Next slide. Yeah, the brain metastasis. Next slide, the same patient. So can I have the next slide, please? Yes, so in June 2016, now the disease is progressing. The patient initially had brain metastasis, started on ceritinib, 750 dose, reduced to 600, and June 2016, progression of disease with contralateral lung metastasis, liver metastasis, and bone metastasis. So it's progression of disease. Next slide. So we all know why the disease progresses on that. Disease resistance to the drug given. So we are, once again, Ashish has clearly pointed out all these various mutations which, render resistance. Next slide. Which tells us that we need to move on to the next generation drugs. So ALK-independent resistant mechanisms are various as listed here. And sometimes, lineage changes can also occur, like small cell lung transformation has been described for both alectinib as well as crizotinib. So all this have to be kept in mind. Next slide. So yes, June 2016, disease progression, as I said, lung, liver, bones, bronchoscopy biopsy confirmed, NGS performed. Next slide. Yes, so what options do we have? As we all know, resistance, we could move to alectinib because at that point of time, alectinib was available. And alectinib, as we all know, acts well on the brain metastasis as well, besides the extracranial metastasis. Next slide. Yes, this has already been attributed to. Can we move on to the next slide, please? Yes, and at the IASLC was where the ALTA trial was presented, and it said brigatinib, it compared actually brigatinib one dose with the other, 90 mg with 180 mg. And once again, progression-free survival was evaluated. Next slide, please. Yes, so survival in crizotinib resistant patients, as you can see here, once again, a clear separation right from the beginning with a good hazard ratio as well, in terms of both PFS as well as overall survival in favor of brigatinib. Next slide, please. Yes, this was the phase 2 study of lorlatinib, the next generation in patients with advanced ALK and ROS positive NSCLC. Next slide, please. This was also present in the ISHC. So as you can see here, both intracranial as well as overall, lorlatinib proved to be very effective in terms of overall response rate as well as stable disease, and also, response was very good. Partial response, a lot of partial response, and even complete response was achieved, both with overall and as well as in intracranial disease. Next slide, please. Yes, efficacy. Once again, this is the same thing in a different ALK positive non-crizotinib TKIs plus chemotherapy combination. Once again, as you can see here, a lot of green and blue, which also tells that complete response has also been achieved, both intracranial as well as overall. Next slide, please, with lorlatinib. Pooled efficacy in experimental 4. Once again, this also tells you the waterfall plot that lorlatinib is clearly effective in terms of controlling the disease as well as getting complete resolution overall as well as in intracranial. Next slide. Can I have the next slide, please?
So this is the last slide.
Oh, is it all? Okay. So now we have seen the various, the landscape, transition of one ALK inhibitor to the other, to the next generation and all this. So we have a choice of all this. Now I would like to ask my pathologist, Dr. Chandramoulishwari. Madam, you're there?
Yes, sir.
Ah, yes.
Yes, sir. Yes,
Madam,
sir.
so
Yes,
what IHC would you now currently do, madam? Are you testing for upfront ALK positivity, or I know we all test for
yes,
EGFR in a metastatic adenocarcinoma lung?
yes.
What
We
all
do
do
the
you test,
testing,
madam?
sir. EGFR. Yes, so it is extended panel or shortened panel. So NCCN actually recommends an extended panel, and in our hospital we do EGFR, ALK, ROS, and BRAF upfront. And ALK is by
Okay.
immunohistochemistry, PD-L1 is by immunohistochemistry. So after finishing the IHC, we send it for molecular testing either by PCR or by NGS. NGS currently we do not send; it is only for PCR. Currently the blocks are being sent for. So ALK immunohistochemistry is usually by, it is FDA approved only by the antibody called D5F3 on a Ventana platform. So only that is FDA approved. And there are many studies which point out that immunohistochemistry is far superior to FISH.
Oh, I see. Okay. Okay.
Yeah. So it is either IHC or NGS. FISH is actually as per the literature, it is considered to be inferior even to IHC, sir, as regards to the sensitivity and specificity.
So IHC, I think should suffice, right?
Yeah,
as far as
only the platform and the antibody has to be taken care of. So it is manual is not approved. On a Ventana platform, using a D5F3 antibody is approved by FDA.
Okay, madam, that was good. So you do a PD-L1 also upfront?
Yes, 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 yes.
By
That
IHC.
also is on a platform. Yes. So
Good.
for pembrolizumab, it is companion diagnostics. So PD-L1 testing we do, and the scoring is actually a tumor proportion score. So for upfront, for first line therapy, the TPS is different for first line and for second line therapy. So depending on what score the clinician wants, depending on whether it is first line immunotherapy or second line immunotherapy, we give the TPS score as to above more than or equal to 1 or more than or equal to 50.
So depending on the metastatic burden, you take the score. Okay, madam. So I think the bottom line is immunohistochemistry upfront, molecular testing upfront in a metastatic adenocarcinoma is of paramount importance. And it's not just EGFR, and we have to do ALK positivity as well as we'll have test for ALK and also the PD-L1. But in our setting, especially I being from a government setting and Ashish is in CMC, we are all differently placed. And so I think the place where we are in the very limited facilities that we have. So we have to work on that, and still histology is of paramount importance, but IHC and all these testing will come in handy. And if we do all this, we're able to do all this, definitely we'll be able to prolong the progression-free survival, give a better quality of life to our metastatic adenocarcinomatous patients. So any other thoughts, Jovita? Anybody else would like to add anything?
Sir, one more thing I want to point out, sir.
Please,
Regards to
madam.
NGS technique, which was spoken about so elaborately for all the extended panels, not necessarily the hotspots. We wanted the extended panel, but for the extended panel also, even by NGS technique, it is the RNA sequencing which has to be pointed out. That is what is considered to be superior. with regards to sensitivity, specificity. So even in NGS technique, it is the RNA sequencing. There is a DNA sequencing, there is an RNA sequencing, there is a protein sequencing also. So for all these extended panels with regards to lung malignancy, it is the RNA sequencing which is considered to be far superior to DNA sequencing and protein sequencing. And one more thing I wanted to say also was regarding the cell-free DNA. Cell-free tumor DNA was also pointed out
liquid
in
biopsy.
this.
Yes, madam.
So liquid biopsy, sir. So for that, the platform is actually digital droplet PCR or NGS. It is not any other. RT-PCR is not applicable for liquid biopsies. It is only either the digital droplet PCR technique or the NGS technique which has to be applied for.
So anyways, we need the NGS going to get that done, right?
Definitely.
The liquid biopsy.
Yes.
In our government setting, is it available anywhere, madam, if at all?
Sir,
I'm not sure whether no way.
IHC, yes, sir. IHC for PDL1 and ALK is available, sir.
Okay.
Ma'am, is that the same as a scorpion-based amplified technique? What is that?
Ma'am, I'm not aware of that. What is it actually for, ma'am?
PCR. It's a kind of PCR where they are able to amplify better. Like the droplet digital, this is that scorpion amplified kind of. I think there is a test. Okay.
No, I have not heard about this.
Okay.
I'll look it up, ma'am.
Actually, thank you, ma'am. Sir, actually, I wanted to, give a thought of mine that
please, Jyota.
being the latest drug that we have in our armament, that happens to be a synthetically driven, synthetically devised drug that specifically targets the CNS disease. So I think that would be a very good option. And one more point I wanted to add for the benefit of everyone is that there is a mutation which is C1156Y and L1198F. These two mutations alone will not be sensitive to any other drug except
Lorla. That's right.
Yeah. So since we have such kind of situations where it is so specific on a particular drug, I guess NGS becomes very, very mandatory in the future. And we would have to look upon developing such technologies so that the common man would be able to do. NGS is not really possible for everybody. And also probably to develop drugs such that we'd have generic brands evolving so that everybody would be able to get it. This is my thought, sir. Yeah,
that's right. So probably what you're telling is a multi-gene assay at the outset is what is the order of the day. So we pick up the minimum tissue that we have that everybody was speaking about. So you test everything, so you find out what mutation is there. You could probably choose the correct drug right at the outset, right? So yes, I think anybody else would like to add anything? Anita? Yeah, thank you so much.
Yes, thank you. Would invite Dr. Rajkumar. The panelist remains
thank
the
you
same.
Very much. Thanks for your time.
Any further questions to be discussed, Dr. Rajkumar?
Ma'am, Rajkumar sir has not joined us.
Okay, then we will just I just put this question to my panelists, is that suppose if a patient is having, like we know that this mutually exclusive EGFR and ALK. Now what happens if you are having a PDL1 along with an ALK mutation? Anybody can tell. And do Dr. Chandramolleshwari, what is the method of, do we run the PDL along with the ALK or how do you do it?
Yes, ma'am, we do. So ALK and PDL1 is by immunohistochemistry, and PDL1 we have a companion diagnostics for pembrolizumab. It is done again on a Ventana platform. So the scoring which we do after the staining for PDL1 is called tumor proportion score. So we give the score, and if it is more than or equal to 50, it is useful for first line therapy, and if it is more than or equal to 1, it is useful for second line immunotherapy. So scoring is actually based on the presence of membrane staining. The intensity does not matter. The tumor stained in the membrane is counted and it is expressed as a tumor proportion score.
Now to the
and pitfalls, of course, are there. We need to be beware of the macrophages also. Yes, ma'am. Please go ahead.
To other panelists, if both are positive, what do you do? How do we treat the patients? Or have you tried the dual therapy?
Yes, Anita's question, if I'm right, is PDL1 positive as well as ALK positive. So would you give both? Would you target both? Yes.
Beautiful question, ma'am. There are trials and there are studies which has tried both the agents together, and it's a very, very important question to address as well.
Hi, ma'am. Kripa here. If I can just quickly take that question to you. I think in the presence of a driver mutation,
You don't.
immunotherapy it just doesn't work well at all, and that's been clearly established across the board for all types of driver mutations. So when you have a driver mutation, look at targeting the driver mutation, especially if it's an actionable mutation. So I think that's the way to go forward. And we're looking at second generation and third generation ALK inhibitors as well. So if you have an ALK mutation, look at targeting the ALK mutation, especially the EML4 ALK translocation that happens, and you look at targeting that in the first line, and reserve your immunotherapy for later lines when the patient actually progresses. And that's the funda across the board for anybody with an actionable driver mutation.
That's right.
Thank you, Dr.
Good, Kripa.
Kripa.
Thank you.
Yes,
I just wanted to add on that.
Yeah, tell me.
Usually the ALK positive patients are very low on immunogenicity. So they may not work very nicely for PD-L1. So definitely, as Krupa has said, ALK inhibitors would be the choice, and PD-L1 can be probably kept maybe third line or fourth line. If everything fails, probably you can go for chemotherapy, immunotherapy in those settings. Am I right, Krupa?
Yes.
Right as always, Bhavesh. I absolutely agree with you. I think you would probably reserve immunotherapy and chemotherapy later on, especially post second or third line. Obviously, in somebody who's got an ALK mutation, because you would look at identifying the resistance mutations as well in the second line. And sometimes you can have a change in histology, as Dr. Prem Kumar sir also rightly pointed out. In that case, you would want to go in with chemotherapy, and then reserve your immunotherapy in the third line and so on. So it basically depends on the type of resistance pattern that the patient develops. That will dictate your second line therapy and so on.
So
there are many trials, as Jovita was mentioning, many trials with combination ALK plus PD-L1, ALK plus targeted therapies, ALK plus anti-angiogenic therapy. So many trials are going on, but I don't find any trial where ALK plus chemotherapy is going on.
Yeah.
So
correct.
Anybody has any thought why nothing
So,
like that
so
has been
if I may
tested?
say, sir, if I may say,
Yes, Vikas.
So we have crizotinib, ceritinib, alectinib, lorlatinib, brigatinib, ulixertinib, and two more in pipeline, which I can't pronounce right now. But it all shifts the immunotherapy down to the lane. And wherever the immunotherapy has been tried in ALK positive patient, the response rate that means even a partial response or a stable disease has been zero.
Very less.
So probably it is in the 8th or the 9th line of therapy, I would give the immunotherapy. And probably that would be also what the combination would be: the atezolizumab, the bevacizumab, the carboplatin, and the paclitaxel. So
ABCP
giving
type.
4 drugs, ABCP in the 8th line of the therapy, when probably the patient is half on a stretcher and half on a deathbed.
My question was that is there any trial where ALK and chemotherapy is combined? Like we have seen so many with EGFR and chemotherapy. But
Sir, all across the response rate has been zero. So not even a stable disease, then probably I believe that there is no role. If ALK is positive, I would reserve doing a PD-L1 also on the patient.
Always
correct. I agree with that.
Driver mutation, target that. Yes.
Yes, Dr. Bhavesh, you carry on and just if any other burning question and give your final remarks. I think we covered almost all the subjects.
So it was very nicely covered from the beginning till now. Everything was covered very nicely, starting from just a diagnosis of lung cancer, coming to small cell, non-small cell, then non-small cell further into adeno, squamous, large cell, and then coming now to each and every targeted. I think nobody accepts the diagnosis of CA lung only, and everybody wants a driver mutation, at least minimum of EGFR, ALK1, ROS, BRAF. These are very PD-L1. So this at least 5 things even I am doing here, even in a place like Namakkal. So I accept that I expect that everybody is doing at least this panel. Which is very much targetable now, and all the drugs are most of the drugs are available for usage. When we see ALK, as Ashish has already mentioned, the overall survival are phenomenal. Like if we are able to sequence the drug properly and patient is in a good condition to take one after the other drug, followed by chemotherapy and immunotherapy, as Vikas has told, probably 8th or 9th line of therapy. then probably we see 5-year survival rates to be in a very high proportion, which we have not seen in any other targetable mutation. So definitely ALK is here to stay, and there are more and more drugs which are coming, 5th generation, 6th generation probably in pipeline, and hope they'll have more effect and less of side effect. That's what I expect from them.
Yes, thank you, Dr. Bhavesh, and thanks to all the participants, chairperson, expert comments, panelists for having meeting all of us together here. I thank to everybody and have a nice Sunday. Sunday is almost over. Happy Kartikeya Deepam today. Thank you so much.
Thank you.
Thanks to
All.
Kavina
Thanks.
Creation and thanks to Freedom from
Thanks,
Cancer.
Anita.
Thank you so much.
Thank you.